Okay, let's get started, right? Karibu, everyone. I know it's 3 minutes past the hour, but usually we'll see quite a few people, join. I would say maybe 2 more minutes if that's okay with you. But Karibu, thanks everyone who keeps sending us like messages on how you're doing with the USMLEs. I mean, it's really encouraging, and I know that this is not a journey for everyone, but it's also always nice to get messages, by the way, from your students. That's like always some of the things that bring the most joy. And so hopefully everyone is doing well, getting, vaccinated. And yeah. So Walter, do you want to get started?
Yes. Ladies and gentlemen, welcome today to another session. I'm super privileged today again to be here and talk to you about some concepts in psychiatry that can help you in the USMLE. I'm not sure. I think for this presentation, I thought we should start from last week. A few things that we kind of didn't conclusively talk about. So I'll start there. Let me try. My slide is not moving. Okay, yeah. So again, Mogeni Walter, that's my name. I'm presenting today. I'm a psychiatrist PGY1 at Broadlands Unity Point Hospitals. And usually I'm joined by Dr. Gichoya was just talking, and she's an interventional radiologist in Emory. She has a lot of titles that I'm not able to complete today. And also Dr. Newsom, sometimes she joins us, most of the time actually, and all of them, they're in Emory. So if you wanna check some of these videos, they're on YouTube. You can check on Mogeni and the Gichoya notes, and you can always review them. So today, I'm not sure, Dr. Gichoya, if we can have the poll, and also if we can have them unmuted from so that they can discuss.
We tried this, and just because people join from many things, and sometimes they're not in a quiet place, it takes a lot of work to manage. Yeah, that's why we tried this like 3 or 4 times, and it was, like there's noise, there's quite
people forget that they are on. Yeah. Okay, sounds good.
Yeah,
I mean,
so I would just
yeah, I think,
yeah, I mean, we can try it again, but it's very disruptive.
Yeah, I think you can
sometimes
mute them,
you just listening in as you do.
Then they can unmute whenever they want to talk. I think.
Okay, I'll do that.
Start today with the review of last week's few questions that we had some issues to talk about. We'll also talk about some eating disorders, some mood disorders, maybe mostly questions. We look at psychopharmacology with the emphasis of side effects. And in the meantime, I'll give you some tips on how to answer these questions, on how to prepare for the USMLE. And that's why we're here today. So a review from last week, we had a question. Actually, I'm teaching psychiatry, but this is an HIV question. And we were not very conclusive on this topic. So if I can go back to you and tell you what happened, is that we had this patient with HIV and was presenting with some mood symptoms. So, but the question was like, what else do you know about HIV? And I kind of went deep and tried to look for answers for this question. And the question was, in approximately a third of HIV-infected patients with CNS changes, which of the following is most characteristics in the post-mortem brain? So I gave you an answer last week, and the answer is C, vacuolar changes of the spinal cord. So from my review, it's like vacuolar changes of the spinal cord are mostly associated with HIV-infected patients, and the other disease that can present almost similar with vacuolar changes will be vitamin B12 deficiency, and mostly it's the spinal cord. So D is wrong because it doesn't spare the spinal cord. That's where kind of it presents so much. Loss of oligodendrocytes and neurons, that is for multiple sclerosis. If you see that, think about multiple sclerosis. So A and B, I did not get a distinct disease that is associated with this, but they talk about brain atrophy, especially if you're talking about subcortical changes, or maybe brain injury if you're talking about neocortical atrophy. So those are the other things that I kind of thought maybe I should talk about today. And actually, Dr. Gichoya, if you check, I think if you check on the internet, if you type in VACUOLAR changes or something on Google, you will see a lot of MRIs showing VACUOLAR changes. And maybe if you get a good picture of something, you can talk about it at the end of this or something like that. So,
okay.
Yeah. Then, so this is just a summary of this. AIDS-associated vacuolar myelopathy is a common neurologic complication of AIDS. Pathologically, vacuolar myelopathy is characterized by vacuolization in the lateral and posterior columns of the thoracic spinal cord and has a striking similarity with the myelopathy of vitamin B12 deficiency. So in autopsy, up to 55% of patients with AIDS have evidence of spinal cord disease. So it's very common in the spinal cord. So this is just to remind you that we're not studying psychiatry by exclusion. You can have some of these concepts that you might need to know for pathology. Pathology is very high yield in the exam, actually. So another high yield concept, I confused this when we were talking about it last week. I kind of said, let me not say what I said, but capacity is basically decision-making. Capacity is done by the physician and competence is by the judge. So if you see anything like competence or anything like that, that is a judge, that's not your business. So that should be the most correct answer or the most wrong answer when you're dealing with those questions. And this is a concept that is very testable, and they will test you on this for sure. We also talked about paraphilias, and you remember frotteuristic and fetishistic disorders. It's good for you to differentiate these terms because they just come there, and if you don't know, that's it. You lose that mark. So frotteuristic, it's basically when somebody is rubbing against others and they get arousal and they can't stop doing that. They get fixated that they have to do that to make them feel the arousal and satisfy their sexual urges. Fetish is just kind of wearing or using non-living objects and to get that pleasure from that, okay? We talked about sexual masochism and sadism is when somebody looks at someone who is in pain and they kind of enjoy that. For masochism is the recipient. Whoever is receiving this, he likes it to be, he can only be sexually aroused by having like battered, beaten, or anything like that. And we talked about other things like necrophilia. And I said, if you remember, necrophilia is associated with dead people. And those people tend to get sexually aroused with dead people and corpses or stuff like that. Okay. And there are other many terms out there, but I'd like you to remember this so that whenever that question comes up, you can always score those points. And I keep welcoming everybody who is out there for today's session. So I'll briefly go through eating disorders, and there's a bunch of questions that are coming up in the next few minutes. So if you pay attention, you might be able to get those questions. And most of the time we're gonna be using the poll, and I'll take very few minutes waiting for you to answer those questions so that we can be done within 1 hour. So according to the DSM-5, we have these 5 listed disorders as eating disorders: pica, rumination disorder, avoidant or restrictive food intake disorder, anorexia nervosa, bulimia nervosa, okay? So pica is persistent eating of non-nutritive, non-food substances over a period of at least 1 month. So somebody will just want to eat some ice or something like that over and over. And this is not associated with their cultural beliefs or practices. It's just that it's not related to their development, like they are not babies who wants to eat one thing because that's what they think it's good for them. Their development stage is on a level that you cannot attribute to the just kind of development of their brain or anything like that. So that's pica, and usually it comes to the exam, and it can present like a female. It might be a pregnant female who wants to eat only this, and she doesn't want to take any other food. And usually, these things might be associated with other conditions. Pica might be associated with other conditions, including iron deficiency and all that, those other things. But usually this is pica and it's a disorder. Rumination disorder, I think this is new. When I was looking at this, I got a privilege to read through DSM-5 a little bit, but in I don't think we had this disorder in DSM-4. In DSM-5, basically this means repeated regurgitation of food over a period of 1 month, okay? Regurgitated food may be rechewed, reswallowed, or spit out. So regurgitation is not attributed to unassociated gastrointestinal or other medical conditions, e.g. GRD and pyloric stenosis. So I'll not go into details of pyloric stenosis or anything like that, but that's a highly testable concept and usually happens to young male. I think they should be around 3 months old or something like that. And usually there's an olive mass that you feel at the epigastric area, and usually you do a pyloromyotomy or something like that. I think Dr. Gichoya maybe might be doing some intervention on this. So it's highly testable, but what the concept is, it's not associated with this kind of pathology. It's just something that people kind of chew, swallow, or spit out food and regurgitate food. And this is not associated with anything to do with anorexia nervosa, bulimia, or binge eating disorders. Okay, let's look at this. Avoidant restrictive food intake disorder. Avoidant restrictive food intake disorder. So they lack, apparent lack of interest in eating or having any interest of food. So they avoid based on the sensory characteristics of food. So they say this, the way the texture and stuff like that, that's not good for them, and they don't want to eat the food. There's the concern about aversive consequences of eating. So there's significant weight loss, okay? Significant nutritional deficiencies with these patients, dependency on enteral feeding or oral nutritional supplements, and there's marked interference with psychosocial functioning. So if this person is in, you know, even in America, there's people starving right now because of COVID-19 or something like that. This cannot be explained by lack of food, depending on where they are. So if you don't have food, I don't think you're gonna be avoiding anything because already you don't have that food anyway. So that's avoidant restrictive food intake disorder, according to DSM-5. And usually these disorders have to be more than a month of trying to avoid food and stuff like that. So anorexia nervosa, highly testable concept in eating disorders. So basically there's restriction of energy intake. You see another one, restrictive. This is another restrictive. Most of the time it can be restrictive, okay? So this is the concept I want you to differentiate between avoidant and anorexia nervosa. So they have significant low body weight, and usually if you look at the BMI, it's less than 70, okay? So they have intense fear of gaining weight, underline that. The disturbance in the way in which one's body weight or shape is experienced. So they have two different specifiers. I'm being told my internet connection is unstable, so I'm not sure if you guys can hear me. If Dr. Gichoya, you have a problem with hearing me, let me know. Okay, so there are two different specifiers about anorexia nervosa, and usually there's a restricting type, and this can be confused with avoidant or restricting eating disorders, okay? So, but also they have another character specifier of binge eating or purging type. These are the people who vomit, who want to use laxatives, who want to use any means to just make themselves, lose weight and, continue making their desires of losing weight met. Okay, they use all the other kind of means to do that. So how do you differentiate between restricting type of anorexia nervosa and the avoidant restrictive food intake, which tends to be the same? So most of the time it's the weight actually. So if you look at the BMI, most of the time is the BMI you look. For these guys, somebody who had a BMI of maybe 30 and has lost significant weight in the last couple of months and is like a weight of 20 or 21, that is significant. Losing a weight like that for the last 2 months or 3 months, that's significant. And if the patient meets the criteria that I just talked about, that's avoidant or restrictive food intake disorder, okay? But if the BMI is most of the time less than 17, that is now gonna be anorexia nervosa. So just before I go to the next, if you have a question in an exam and the question you're not sure, you have anorexia nervosa right there, you have avoidant, and all the other things around there, bulimia, maybe you're suspecting is bulimia, which can also look like anorexia nervosa. Actually, we'll talk about it. It's good for you to know how to calculate the BMI. Is there anybody there who knows how to calculate the BMI? I'm just gonna try to involve you guys. I'm trying to put on my chart. All right. I'm not getting it. Anything you see, Dr. You sure?
Yeah, Irene said yes.
So can you write down like how you do that?
Weight in kilos over height, m squared.
In meters squared. Perfect. You should know how to do this very quick. Sometimes there's a calculator, if I remember very well, there's usually a calculator in that USMLE stuff. So if somebody has a weight of maybe, let's say, 75 and is 1.5 meters, you should try to know how to convert weight from pounds to kgs, but I don't think they're gonna trouble you with all that. But you should always try to make sure that you know the BMI of these patients if you're talking about eating disorders, because that might help you. That might give you that one extra score. Okay, so BMI calculation is weight in kgs divided by height in meters squared. Okay. All right. So bulimia nervosa is eating in a discrete period of time, eating a lot of food, amount larger than the most individuals could eat in a similar period of time. E.g., within 2 hours, they tend to eat a lot of food. So there's a lack of control over eating during the episodes, recurrent inappropriate compensatory behaviors in order to prevent weight gain, okay? So that's another concept. So I told you this can be also confusing if you're looking at anorexia nervosa, because they have the compensatory mechanism, okay? The bulimics. And if they have the compensatory mechanism, they will be using laxatives, they'll be using, all those diuretics, they will be using, maybe before I forget this concept, is there anybody who remembers if you do a colonoscopy, if somebody is using laxatives, what you see in the colon? Even me, I don't remember. Do you remember, Dr. Gichoya?
I don't think I understand the question, Pastor.
Oh yeah, so patients who use laxatives, okay, and they use laxatives, I think it's something coli. They use laxatives to lose weight, and they chronically using laxative. You see some depigmentation in the colon, And there's a name that goes by that. So that's the kind of name I'm looking for. And if you Google, I think I'm sure you'll get it. But I'm throwing it out there. If somebody gets it, share with us. And that's why I kind of you study these things. You kind of tend to put them together. And what can you see in the
Doreen asked, is it melanosis?
It should be something like melanosis coli or something like that. I thought that's, yeah, good job. And you can check on Google right now and see how that melanosis looks like, and you can add or subtract as we continue. I told you this is a sharing kind of platform. Okay. So so they do all these compensatory mechanisms, and this compensatory behavior at least once a week for the last 3 months. Okay. So let's look at the last concept here, binge eating disorders. So they lack control, they eat huge amounts. This looks similar to the bulimic, the first 2 sentences or 3. But the other thing is they eat until uncomfortably full, eat alone due to embarrassment. They don't want to stay with people. And they feel depressed, disgusted, or very guilty afterwards, you know. Binge eating at least once every week for 3 months, okay? So these guys don't have the behaviors of purging or anything like that, but they tend to have no control of their eating, and they try to, because of now they are not able to function, they feel embarrassed, they start hiding and eating by themselves. There are other kind of eating disorders that if you don't want to listen to this, I'll not blame you. Maybe you'll not see them in an exam. But remember, you can have an atypical anorexia nervosa whereby you have a normal range of BMI, but they're purging type. Purging type, and they kind of have a normal range. And this can confuse you with bulimia, who are purging and they are normal. So as I said, if you don't want to listen to this slide, you can just cross it. It's just a confusing concept in DSM-5. So night eating disorder is another thing that you can see that people wake up, they're very conscious of what they are doing, and they go ahead and, you know, and eat a lot of food at night. Then in the morning, they're like, why do I wake up and go eat a lot of food at night, and what's going on with me? And that may make them not function in their community. What if you have a purging disorder and there's no binge eating? You're not eating a lot, but you just want to purge. So that's called a purging disorder. So as I said, this might not be very high yield, but I think the night eating disorder might be a kind of testable concept. So check on learning. And this is where I like the poll to come up. I have a couple of questions, maybe 15 questions that we should cover in the next 30 minutes. So I don't have a lot of time to wait for you guys to give answers, but I like to give you enough time because the exam, you know, it's 8 hours, and in every hour you have 40 questions you should answer. That means you have less than a minute, less than 1 minute, 30 seconds to answer one question. So can we go ahead and do this? I can give the poll, launch polling, if that is okay with you guys. You have, can you see the poll?
Yeah.
Okay. Anybody else different? I need 2 more people to answer this question. Okay. I will end the poll because we're 40 seconds in. So I would like you to do these questions within a minute so that you can save time for some calculations, biostatistics, or stuff like that. So we have A to D, and most people answered us with a C. All right. And I'd like you to take a pen, write down eating disorders. How did you score about that? Then you can go ahead and revise depending on how you did. So for bulimia, vomiting in bulimia include all the following except. So the word is except. Some of you answered D, and I think you did not see the except part. So Mallory Weiss tears or longitudinal mucosal lacerations. This can happen when you're retching, okay? Russell signs, these are people who try to put their fingers all into the back of their throat so that they can induce vomiting, and they have these bite marks on the knuckles. And if you Google right now, Russell sign, and see the pictures, you can see that. And you should remember that always for your exam. And nobody chose that, and I think you understand what that means. Soft palate lesions, of course, they are taking their fingers back there. They might have lesions. The acidity and whatever that comes from the GI, they can have that problem. And parotid enlargement, you can have parotid enlargement. That's one of the characteristic signs of bulimia nervosa. So when you're vomiting, your amylases tends to increase, okay? Anytime you have a GI problems or something like that going on, your amylases will go high. So it's not that they will decrease, okay? Unless you have questions, guys, you can always put some questions there. Dr. Gichoya can always, kind of tell me what.
Irene asked, why do we have parotid enlargement?
That's a good question. So this is my thought. It might be wrong. Usually, the parotid is connected to the mouth, and because you might have this inflammation going on. I'm not sure if you will have some duct. I'm not sure, to be honest. That's a very good question. I'm not sure. If somebody can check that and share with us, I think it will be good. I don't want to think about it so much. I'm not sure, but that happens when you vomit a lot. So somebody can be Googling that and share with us, and as we keep going, okay? So we have another concept here. The primary cause of reduced bone mineral density in women with anorexia nervosa is, and I'm gonna put the poll. And it's right there. Guys, I'm gonna give you 40 seconds to answer that. Okay. And Dr. Alisha, if you see any explanation for parotid enlargement, you can always share with us. All right, I see only one person answered that question. We have many more, please. From Kenya, Uganda, I'm told Tanzania, Rwanda. Only 4 people. We have 15 attendees. Okay. I'm gonna stop the poll. So if you see, those are the results. Anyway, guys, I really don't mind you failing this question today. And the reason why I put the poll is so that you are anonymous, so that I don't know what you chose. So feel free to always try this, choosing whatever you think. And the moment you fail, I think that makes you better to understand this concept. Anyway, anorexia nervosa, primary cause for reduced bone mineral density in women with anorexia nervosa. And this is the kind of questions you will see in step 1, okay? They might have vitamin deficiencies, yes, but what will cause bone mineral density problems? Vitamin deficiency, yes, maybe if you have vitamin D deficiency or anything like that, but that's not the main cause, okay? Hypoestrogenemia, I'm gonna skip that for now. Hyposecretion of growth hormone, yeah, maybe that can happen, but will that affect your bone mineralization? Maybe no. Hypokalemia, yeah. Usually this patient will come with hypokalemia. So will hypokalemia affect your bone density? Maybe not. Decreased levels of thyroxine. That there's changes in hormones actually for these anorexic patients, but will that affect your bones? So if you remember the bone mineral density, hypoestrogenemia tends to be the concept. So what does estrogen do to the bones? Estrogen tends to decrease the osteoclasts, okay? And also, if you decrease the osteoclasts, you prevent bone mineralization. And if you prevent that, That means the bone is going to form poorly, and these patients can have fractures, easily fracture their bones. Okay, so estrogen levels will go down. There are other things. What is the common thing that is testable that tend to increase in anorexic patients? So estrogen goes down, growth hormones can go down, they can have hypokalemia, they can have hypochloremia, low chloride, because they are vomiting all that chloride out. What tends to be high in the, somebody send me message through the chat box? What tends to be high?
Walter, if you try and just do Alt Tab, you may find the chat box so you can read it for yourself. But Charles found the answer. Yeah, you know, he explained why there's a big parotid gland. It's speculated that cell-omegaly is caused by repeated cholinergic stimulation of the parotid gland, resulting from stimulation of the taste receptors on the tongue that occurs during vomiting. Such stimulation over a long period of time results in glandular hypertrophy.
Okay, thanks. Thanks for that. Fair enough.
And the second answer to your question is bicarbonate.
Yeah, bicarbonate can be high if you think about it. But what I'm looking at actually for anorexia is hypercholesterolemia. They have high triglycerides, high all those things to do with cholesterol. The lipid panel, that's kind of the testable concept that you need to look into. And you'll see those questions and you'll see TGs and whatever high, okay? The other function of estrogen is, it's closure of epiphyseal plates, and that's the other function in terms of bone, how it affects the bone. So, all right, I'm gonna move on because I have many questions, guys. Oh yeah, I got these concepts here. So there's hypogonadism with relative estrogen and androgen deficiency, growth hormone resistance. Okay, it's resistance, not even low. Hypercholesterolemia. What will happen with the ghrelin? Do you think it will be high or low? So I'm gonna give you the answer for that because we need to go. Just choose one from in your head. Will it be high or low, and why? Okay, so the answer is this will be high. What's ghrelin? Ghrelin is, I remember G for glutton. It increases your appetite. So the body will naturally try to push the ghrelin high so that this person tends to try to eat more. Very highly testable concept in the USMLE. And I would like you to remember also, if you can relate this, if you can relate anorexia nervosa with an athlete who is running and they lose weight and all that kind of stuff, what happens? They have ovarian atrophy, they have, the ovaries, they kind of tend to give you the estrogen. So if they kind of have the same concept, but will they have hypercholesterolemia? I like you to compare those two and try after this, if you can compare those two and see. I didn't check much about the athlete, but they tend to have very similar kind of presentation. So just for your information, FYI. We have another question here. So which of the following is typically present in eating disorders but absent in those medical conditions mimicking the presentation of an eating disorder? Okay, guys, 40 seconds. So remember, the poll is anonymous. I don't know who is doing what. So I encourage all of you to try. Be part of this. I mean, that will be very helpful. I have only 29% so far answering the question. Okay, 2 more seconds. All right, I got 58%. And I'm sharing the poll results right there. So guys, yes. So the correct answer tends to be, or the most correct answer at this point, fear of being fat. So basically, that is if you remember what I just talked about, eating disorders, most of this, especially the anorexia, and I said underline that, most of them, they fear of being big. Restricted oral intake, it can be with, if you have GERD, pyloric stenosis, or anything like that, most likely you will have that. If you have a central nervous system lesion, of course, that it's out of the eating disorder. The only thing that is very particular for your eating disorders is fear of being fat, FAT. Maybe I'm saying a different FART or something. But anyway, fear of that is the only problem that is very distinct. Okay, let's go. I have one or two more. This might be a tricky question. Common findings in anorexia nervosa restricting subtype include all the following except. Okay, that's kind of how these people set their questions. So go ahead and 40 seconds. %68%. Okay, that's a fair 75%. All right, so the majority tend to go with E, which I tend to agree with, and this is the reason why. So let me just push this aside. I should have two screens. Dr. Gichoya has been telling me that. Anyway, common findings in anorexia nervosa restricting type include all the following, except. So we're looking for the exception, okay? If you are anorexic, another concept you should remember, this patient will present with hypothermia. What do you think will happen? They have bradycardia. Remember that's a testable concept actually in the exams. They'll put tachycardia and bradycardia. Then you'll be like, okay. So it's bradycardia, bradycardia. Hypokalemia, we said that you're vomiting, you're losing potassium. Osteopenia, we said the estrogen levels will be low, okay? And therefore the osteoclasts will be higher, okay? And therefore you'll have osteopenia, okay? So esophageal erosion. So this is a restricting type. They are not, they are restricting their calorie intake. So they will not have esophageal varices or erosions, okay? Not varices, that's a very different thing. So I hope that is clear. Okay. This might be the last one in eating disorders. Irreversible cardiomyopathy has been associated with eating disorder patients who use which of the following? Okay, guys. What do you think? $40 seconds. Okay. I'm gonna, when I have 60%, that's good enough. Okay. Again, so this concept is like, we use sometimes the syrup of ipecac to induce vomiting, okay? So you might get some people misusing this medication and they tend to vomit a lot. And they can cause reversible or irreversible cardiomyopathy. And that's, so the correct answer is A, okay? So they tend to use that syrup and they can get cardiomyopathy. Is there any explanation I have why that happens? At the moment, I don't, okay? So laxatives can cause melanosis coli, as one of us just told us. Diuretics, you know, They have it depending on which diuretic you're using. High dose caffeine. I mean, that's a good way of saying it, but high dose caffeine is not associated with eating disorders. I mean, if you're using a lot of caffeine, you can have palpitations here and there, but I'm not aware of any cardiomyopathy that you might get. Pica, I'm not sure if that's irrelevant. I don't know if there's some food of some type called PICA, but from me, pica, it stands to be cravings if you're talking about iron deficiency. But if you're in psychiatry, you're eating something that is very non-nutritious, and maybe it's not gonna be helpful to you. I hope I'm answering most of your thoughts on these questions. And okay, sorry, this is the last one. Typical signs and symptoms of anorexia nervosa restricting subtype include all the following except okay. Anybody else? This should be 30 seconds or so. One more person. Just one more. There's a reason why. Okay. Can the one person change the mind? Okay. No problem. I'm gonna share these results. This makes me feel really good that my teaching has been 80% successful. If I mean, if you said orthostatic hypertension is an increase in serum transaminase levels. If you say that, I mean, I share with you what I kind of think what you're thinking about, but remember this, I just talked about this concept a few minutes ago, and I'm gonna emphasize on it. Typical signs and symptoms of anorexia nervosa, underline, restricting subtype, okay? Restricting subtype. So that means they are restricting their calorie intake, okay? What does that mean? They are not purging, they are not using laxatives, they are not vomiting, they are not using syrup of ipecac, so they will not have Mallory waist tears, okay? Okay, so if you're not eating a lot, what do you expect with your GI? The GI will start going slow so that it gives more time, anything that you eat, to be absorbed. It's kind of, you know, that balance the body is gonna try to obtain. And we said again, bradycardia associated with anorexia. Orthostatic hypertension, this can be associated with anorexia. If you're vomiting a lot and maybe you're using all these kind of medications, sometimes you can have problems with your liver. You can have transaminitis and increased liver enzymes. And they might be mildly elevated, but not very significant, like alcohol use disorder or anything like that, but you will not have these Mallory waist tears. And usually, sometimes they don't tell you Mallory waist tears, they tell you longitudinal tears. So remember, they are longitudinal, they are not vertical or anything like that, they are longitudinal tears. And they can involve veins or arteries or anything like that. All right. So we should change gears soon and talk about some mood disorders here. Any question? So I have another case series that I want us to go through very quick. I kind of underlined what I want you to carry forward from each of these. But before even we talk about this case, let us look at question number 1, because this is the concept I want you to carry when you're doing the exams. Let's look at question number 1, and we're gonna go back, okay? So has been canceled that in utero exposure to lithium may increase the incidence of Sutton syndrome. Which feature is associated with this syndrome? I kind of hid down the syndrome. Who knows the syndrome? Can you type in quick? Anybody in the chat? right. If I lost my chat, Dr.
Epstein anomaly.
Perfect. Thank you. So Epstein anomaly. So what is the answer? I'm gonna pull my poll quick. So that's my poll right there. Yeah, Victor said Epicac has hematine. Hematine is toxic to cardiac muscles. Thanks. I appreciate that sharing. That's awesome. If you say that to some professors, they'll be like, wow, but how did you know that? This guy is studying a lot. I like that. Self-directed learning. All right, we 30 seconds in, and I'm gonna stop this in the next 2 seconds. Anybody else? No. Okay. So, yes, Epstein anomaly, guys. Basically, Epstein anomaly is the atrialization of the ventricles. So the atriums kind of tend to go down to the ventricles, and I'll show you a picture. But anyway, I was trying, the reason why I started with this picture, and I'm not gonna go back to it, this question, is that sometimes these questions, they are so like, you have all this to deal with, but the question might not need you to think about the entire question, you know? So you can save time, especially if it's one question or two, you can save a lot of time and keep going. So the correct answer is A for now. But mitral stenosis tends to be associated with old age. It can be associated with rheumatic fever and stuff like that. Usually, sometimes stenosis, then it can end up to be a regurgitation. Transposition of great vessels, this is more of a developmental anomaly. Cleft palate, what is the common cause of cleft palate? Anybody knows? If you can type in quick. I just need one person to answer that. Dr. Gichoya, if you see anything, my chat kind of comes in and out. And I promise next time I'll try to look for 2 screens. Anyway, anybody who typed in anything? Nothing. Mental retardation is not really associated with anything else. So cleft palate, if you see somebody asking you what mostly causes cleft palate, most likely it is multifactorial. That is the correct answer. If you are thinking about that, multifactorial. Anyway, I will quickly talk about the Epstein-Barr before I go to question 2. Epstein anomaly, you see that the valves are floppy. They are kind of going down into the ventricles. That is the anomaly we're talking about. And it's very associated with lithium exposure, especially the first trimester. Let's look at question 2 and see if we really need the concept to go back to the question above. A therapeutic lithium level for bipolar affective disorder is best determined by which of the following? A, blood level between that and that at 12 hours after last dose, blood level of this and that at 12 hours after last dose, remission of symptoms on clinical observation, blood level of 0 that at 24 hours after last dose, remission of symptoms plus blood level at that at 12 hours after last dose. We'll go back to the case. So just allow me to do this. It might be very helpful when you do the exam. I need 50% of you, then we can keep going. We don't need to take 40 seconds in this. Oh man, we almost late. Anyway, guys, I'm gonna stop the polling and you guys can be sharing the other side because we don't have a lot of time. The correct answer is E, remission of symptoms plus, okay, blood level at 0.8 to 1.2 at 12 hours. The reason why we do 12 hours is because most of the time we do dosing twice daily. So just before the next dose of lithium, okay, that's when you're gonna go ahead and check the blood levels. Then know that it's between 0.8, but remember, it can be therapeutic if it's within, if there is remission of symptoms and it's within that range, okay? Perfect. Okay. Considering the patient's history, which of the following could be the least appropriate treatment to the recommendation? This is the question that will need you to go back to the case. And I'm gonna go back.
Okay, sure.
Somebody talking. Anyway, so that is the question that will need us to go back and see what is going on. So Mr. So is an attractive 25-year-old aspiring singer who has been marginally followed in the local clinic for 3 years. She had her first manic episode at 22 when she was hospitalized with flight of ideas, euphoria, and hyperactivity. With her first manic episode, she had the delusion that she was the double of the singer Madonna, okay? That is grandiosity, okay? Because Marilyn Monroe's voice followed her everywhere, telling her to dye her hair blonde. The police had brought her in after she had created a disturbance at a local record store by attempting to stage her own concerts, trailed by several homeless men. She was treated as an inpatient in the time with full remission of symptoms. The resident documented at that point that there was no history of substance abuse, family history was negative, past medical history was negative. The patient had responded well to a combination of risperidone and lithium. As I told you guys, you remember, any acute mania, we start with an antipsychotic, but we can give a mood stabilizer as lithium. So they are saying that was started on those two. She was discharged home where she lived with a succession of boyfriends, okay? Not that one. She managed to support herself with waitress jobs, which changed about every 6 months. So she's changing jobs. She's also able to book occasional singing gigs at local bars. Compliance with the lithium was ongoing struggle between the Miso and her psychiatrist at the clinic. She managed, however, to remain out of the hospital. She was lost to follow-up until 6 months. At this point, the obstetrics residents called because the patient presented to a prenatal visit at 20 weeks gestation. She did not know who the father of the baby is. So 20 weeks gestation underlined that, but is living at home with her boyfriend. The obstetrician's residents report that the patient is somewhat irritable but does not appear to be psychotic or mania, so just irritation. So let's go to number 3. Considering the patient's history, which of the following will be the least appropriate treatment to recommend at this time? Involuntary hospitalization, restart risperidone, social work consultation, close prenatal care, urine toxicology screen. Any answers in the chat box? Dr. Gichoya, how many minutes do I have?
I think so it's 10:56. There's an A in the chat box, but it's 10:56. So
yeah. Okay, let's keep going until Dr. Gichoya, you stop us.
Okay, we'll end at 11:10.
Okay, sounds good. So A tends to be correct. The patient is just irritable, so we cannot go ahead and hospitalize this patient, okay? So the patient does well until 1 week after delivering a healthy baby girl. At that time, she is brought in by the police from a local record store where she was singing the Madonna song like a virgin in a loud voice, draped only in a white bedsheet. In the ER, she was euphoric, hyperactive with flight of ideas. She reported that she was talking to the voice of the Virgin Mary because she was a baby, like Madonna's Madonna, okay? So what's true regarding the onset of psychosis associated with pregnancy in the general population? So I'll help you with this question, okay? So most episodes begin before the 3rd week postpartum. Most episodes begin between 3 weeks and 12 weeks. Most episodes begin after the 12th week. Most episodes occur only if there is a premorbid history. If somebody has an answer, keep typing it there. But this is what you should remember. In pregnancy, most episodes begin before the 3rd week. Okay, so the 1st month, usually before the 3rd week, that's when you see. So A should be the correct answer, okay? If you're not thinking about that. Unless there's a question, I'm gonna move on. Okay, so how does Ms. So presentation compare with that of other postpartum psychiatric syndromes? She is unusual in that majority of postpartum disorders requiring hospitalization are schizophrenic, other than affective. She's fairly typical in that majority of postpartum disorders requiring hospitalization are affective rather than schizophrenia. So paranoid psychotic syndromes account for the majority of psychiatric syndromes following childbirth. Bipolar affective disorder confers a higher risk of postpartum psychosis than does unipolar disorder. The risk of homicidal activity is no greater for Ms. So than for someone whose psychosis is unassociated with pregnancy. So, guys, this might be mouthful kind of slide. But again, if somebody has not answered, that's still okay. But I'm gonna help you with this. This patient is looking at B, the patient is fairly typical in that the majority of postpartum disorders requiring hospitalization are affective rather than schizophreniform. So affective means it's either you sad, you happy, or if you're talking about affective disorders or mood disorders. That's kind of what they are talking about. Most of these patients will not present with psychosis, but mostly they'll present with either mania or maybe they'll present with depression. But most of the time, actually, they present with depression. But this patient presented with mania. So they kind of tricking you if you know about depression more than mania, but affective covers both of them. So B tends to be the correct answer. The patient is hospitalized involuntarily from the ER on the service. Ms. So preaches the word of the Lord to other patients. While actively hallucinating, she retains some reality testing about her infant and is concerned that her parents may not have the resources to take good care of the child during her absence. Okay. So, what is the best medication option for this patient? Do you think what do you think, guys, we should start this patient on? Continue risperidone and start lithium, discontinue and initiate olanzapine, continue risperidone and initiate venlafaxine, continue risperidone and initiate scheduled clonazepine, continue risperidone at current dose and move patient into quiet room. So, anybody chose any answer? Victor, is that Victor? Or maybe that was for the previous one. So I'll help you with this. So if you remember this question, is that the patient was doing well on risperidone and lithium, but was lost to follow-up, okay? So if the patient was doing well, you wanna start the medication that the patient was on previously. So A tends to be the correct answer. The reason why C is not correct, venlafaxine is an antidepressant, okay? So if a patient has mania, do we give antidepressants? We're gonna send them to mania. Do you know what antidepressants do? They activate you. They wanna activate you. So mania is somebody who's hyperactivated. You don't want to give any antidepressant. So we usually don't give antidepressant. There's only one scenario that we do, but I don't want you to remember that for now, unless you're in psychiatry program or anything like that. So because Irene, you answered, that's why I was able to explain about venlafaxine. So if I see answers, maybe I can throw in some concept here and there. All right. So you should do all the following in managing her agitation, except physically or chemical restraints when harming self or others. We usually do that, okay? Preferentially interviewing her when standing in the hallways together. Somebody is manic, you don't want to stand with her in the hallways and start interviewing her. You want to make sure that the patient is calm, seated somewhere, and you can have a conversation. Using her last name as a sign of respect, usually that's what we do. Careful attention to all nonverbal cues that suggest anxiety or anger. You should be very careful and see whether they are getting irritable or not. Avoid interrupting her pressured speech. Always avoid that because that will become confrontational. So the correct answer is B. Do not stand and talk to this patient. Okay, the other things looks correct.
So do we continue with lithium in pregnancy?
That's a good question. So if you remember, I said lithium is usually, you will give you Epstein-Barr anomaly, Epstein anomaly, not Epstein, but I'm talking about virus. Okay, Epstein anomaly in the first trimester. So this patient is already 20-something weeks. Okay, so is there anything? Are we gonna get the anomaly? No, and we can do it in pregnancy for sure. Okay, so we don't have very many choices, like safest choices to use in pregnancy. There are some we try to avoid, but we don't have a lot of statistics. But we can use it for the benefit of the baby and the mother. You see, they are agitated, they are all over, and they can cause death themselves and the baby. So we do. So the patient has a good response to treatment and is discharged home. Unfortunately, she's once again lost to follow-up. She reappears in the ER about 1 year later, this time 10 weeks pregnant and again hallucinating, delusional, and irritable. She's not taking any medication. She's alert and fully oriented, but cannot concentrate and refuses to cooperate with mini mental status exam because the examiner is a priest of the devil. That's what she says. The medical workup, including urine toxicology screen, is negative. What is the false statement? ECT is an appropriate option for refractory mania in pregnant patients. Yes, we highly use ECT in pregnant women, especially if they have mania or they are super depressed. Use of anti-epileptic medication like Tegretol and Depakote have risks to the developing fetus. I hope all of you know that. High potency neuroleptics must not be used during pregnancy. That's a wrong statement. We use antipsychotics. There is some that we think they are safe, like haloperidol. We do use them in pregnancy, but we use high potency, and that's a wrong statement. Maternal use of BZs presents a risk of withdrawal symptoms in a newborn. Yes, if you're using benzodiazepines, if you're using opioids and stuff like that in pregnancy, most likely the baby will also withdraw from them. So you watch out. A mother using heroin or a mother using benzodiazepines, the baby can withdraw. Lithium is secreted into breast milk. Yes, it is secreted in breast milk. All right. Which of the following is the least important in optimizing compliance with outpatient therapy? Simplifying dosing schedule of medication. So the moment you simplify the dosing, that means the patients will most likely comply. Improving therapeutic relationship, you're gonna talk to the patient nicely, have a rapport, and they will comply. Asking family and community supports to take some responsibility for helping her attend appointments and take medications. Yep. The family to talk to her and encourage her to attend meetings and comply to treatment. That's correct. Transportation assistance. If the patient is not able to come to the hospital, you want to help them to come. Occupational therapy, they might not help you with compliance because they just go there and see how these people live and do their job as occupational therapists. So D is the correct answer. We don't have questions. I had the last section and I think I have 4 minutes. So a patient is begun on ziprasidone, which is Jordan. What is the primary contraindication to using this medication? I need to put a poll on this one. Guys, I have very limited time, so ziprasidone, anybody who knows Jordan, we usually call it that way. If I go up to 20 seconds and nobody, I'll go ahead and answer by myself.
The other thing we can do is that this also seems to be anyway, you have 4 questions. I also was going to suggest that this can be a segue for a future review, but people are voting, so
yeah,
that's good.
Yeah, I just want, I think 2 people. I mean, I'm sorry guys, did I give you very tough questions? I apologize. This is not, anyway, we have 2 people who answered the question, and actually the correct answer is D. So ziprasidone, the primary contraindication, Jordan, if you see this in an exam, and which is very highly testable concept, especially if you're thinking about EKGs and ECG and stuff like that, QTC prolongation, that's what we get scared about this ziprasidone. Ziprasidone is very weight neutral, okay? Weight neutral, so it doesn't cause obesity like olanzapine. Olanzapine will give you obesity, it will give you elevated blood sugar, and those actually A and B is more of olanzapine and even most of other antipsychotics. Concomitant use of lithium, we usually, we don't have, I have not seen a contraindication actually to some. Most of antipsychotics we use them with lithium. So prolonged QTC is something you might need to remember. Hyperprolactinemia, risperidone, very common problem that we have with hyperprolactinemia, and sometimes you need to monitor that. Okay. Clinical picture of mood changes in cyclothymia may closely resemble the reactive mood changes observed in. So cyclothymia is kind of having hypomania kind of symptoms and depression over 2 years. Remember the concept for cyclothymia and dysthymia is 2 years. Dysthymia, which is choice number C, tends to be depression for more than 2 years, okay? You constantly depressed, and maybe few days you're okay, but you constantly depressed for 2 years. Cyclothymia is more of mania, so C cannot be a correct answer. Delirium is waxing and waning. It's usually associated with infections and stuff. Chronic pain disorder, that is not related to cyclothymia at all. Bipolar affective disorder type 1. So I said cyclothymia is hypomania. Type 1, it's mania, so it cannot be the same. Borderline personality disorder, actually you will see most patients out there diagnosed with bipolar disorder, actually they don't have bipolar. It's because they have borderline personality disorder. Because they have this hypomania, you're not sure where they belong, you just call them bipolar, but they are borderline personality disorder. So the correct answer is B. So remember those terms, cyclothymia, dysthymia, what they mean. Dysthymia, depression, cyclothymia, hypomania. It's prolonged. The period is over 2 years. So this is my last 2 slides, okay? And I'm gonna be giving you some concepts and hope you remember this. I'm not going to ask you questions, guys, because I'm out of time. So these are the commonly associated effects. If you have somewhere to write and you can remember this, I'll encourage you to do that. So mirtazapine is an antidepressant. It's usually an alpha-2 antagonist. And we use this medication to help somebody to sleep. So that's one of the side effects. It causes increased sleepiness, okay? If somebody is depressed and they don't sleep well, we want to give them mirtazapine. The other thing is weight gain. If we see somebody depressed and losing weight, this one helps you to increase weight. So weight gain and sleep. Nefazodone is very close to trazodone in terms of how they act. Nefazodone, its side effects majorly it's liver injury, okay? It can cause acute liver failure. Lithium intoxication, I think I talked about lithium intoxication a few months ago. If you have lithium intoxication, you will present with ataxia. You will present with changes in vision, okay? You will have tremors. That's one question I ask patients who are on lithium. Can you show me your hands and stuff like that? And if I see some tremors, I'm like, have you noticed this tremor before? Then I keep monitoring that tremor. They can change color vision, color changes in their eyes, you know? They see blue, they think it's maybe green or something like that. So remember those. Lithium intoxication tends to come to the exam, and we usually have to monitor this. Promethazine will give you oculogyric kind of eye movements, you know, kind of dystonic reaction. Paroxetine, it gives you anorgasmia, sexual dysfunction. Trazodone, remember, trazodone, priapism, okay? It's not very common. We use trazodone all the time for sleep. Actually, trazodone, we use it for sleep. It's an antidepressant, but most of the time we use it for sleep. So priapism and sleep, it can cause sleep too. Olanzapine, we just talked about it, and it causes weight gain, and also it can cause, you know, metabolic derangements, and you know that, you know. And Geodon, we said it's weight neutral. You know, it's already, again, just to remind you, Geodon is weight neutral. It does not increase weight, but QTC prolongation, that's the problem. If a patient is on clozapine, these are patients who you want to monitor their every single day, every week. Then we go to 2 weeks, then we go for a month, and then we keep going like that, okay? Bupropion, Wellbutrin, this is the medication you want to avoid in eating disorders because of what? Increased chances of seizures. Bupropion will make you have insomnia. Remember, insomnia, make you not sleep. So we tend to dose it early in the mornings, okay? So seizures, highly testable. We don't use it in eating disorder because the seizure threshold goes down. Lamotrigine causes a rash. It can cause Stevens-Johnson syndrome. Even carbamazepine, actually, to Asian communities, can cause a rash, which is more of a Stevens-Johnson's kind of rash. Phenytoin, I hope all of you remember that it can cause hypertrophy of the gums. And if I'll recommend you to look on YouTube or Google right now, like how phenytoin gums look like. It can cause neurotube defects, and it can cause acne. This is highly testable. And I think, if I don't remember, I'm not sure, you can check this, if it causes hypertrichosis, like hairy kind of skin and stuff like that, hypertrichosis, and it's highly testable. So this is my last question before I finish. The patient is hospitalized and started on olanzapine. If the patient started on olanzapine, over the next few days, he noticed to begin posturing, standing still with strange arrangements of the limbs in the hallways with prominent psychomotor slowing. The patient is likely developing what? This is the last question. So guys, if you allow me to put the poll out there, and then we will be done. And thanks for giving me like 4 minutes extra. I should be done. I don't know if I continued this. Okay. So, yeah. I'm sorry, this might not be the correct polling. I think some of, so this is, I told you last week, if you remember, and I showed a diagram. I was like on camera. I'm sorry, today I wasn't on camera. I showed you of somebody who hangs like this, posturing, okay? Posturing. If somebody is posturing, that's more of catatonia. There are many other symptoms that might be related to posturing, related to catatonia. There are many out there. And if, for example, you tell this patient to stick out their tongue so that you pierce through their tongue with a needle, most likely they'll give you the tongue. That's catatonia. That's another symptom you use. You tell them to resist you, and you push some pressure on their hand, and they keep going up and not resisting you because they are doing exactly the opposite. They may have some waxy flexibility or rigidity, like you're gonna stretch their hands and they tend to have this waxy rigidity or flexibility on their hands or something like that. So that's kind of catatonia. So if I was doing this exam and I see extrapyramidal symptoms, I mean, tardive dyskinesia, akathisia, those two are extrapyramidal symptoms. So A, C, and E tends to be wrong, okay? Then new delusions regarding movement. You know, a delusion is a false belief. Unless you talk to them and they tell you they believe in something or whatever, that's not a delusion. So catatonia tends to be the correct answer. And this is how you kind of, you know, rule out and rule in these kind of symptoms. So I think tardive dyskinesia, you know that it doesn't develop within few days. Tardive dyskinesia develops after at least 6 months of treatment, usually. And it can have lip smacking and all that kind of good stuff. And we can look for time. We talk about these symptoms in a later date. So akathisia is, you see somebody tapping their legs all the time. They don't want to sit still. That is akathisia. Dystonia is like somebody's neck kind of tends to be stiff and looking to one direction. That tends to be dystonia. But akathisia is they don't sit still. These are very testable concepts in the USMLE. I hope you guys enjoyed this session, and this is the end of my presentation. Any questions?
Awesome, thank you, Walter. Thanks, everyone, for staying through. Do you want to introduce the next week's guest?
Yes. So I'm not sure whether that was a question there, but
No, it's thank you. Someone saying thank you.
okay. So next week we have, she's trying to debate. So let me introduce her first. So she's Dr. Miriam Musheru. She's an endocrine surgeon. She's currently on her fellowship program in Wisconsin. So she wants to teach you guys, she really wants to teach and help you through the USMLE, and she wants to start with endocrine physiology next weekend. But I talked to her yesterday and she was like, she has something she has to do in the morning from 8 Central Time. So she might push the timing maybe a little bit later. So just watch out for that. And I hope she will be able to join us next week. If she's not able to join us next week, we can arrange for the other week or something like that. But I'm positive, okay?
So if she's not able to join in, then I'll finish the chest X-ray talk that I started. Rather, I'll continue with it. It's probably going to take 3 times. That's just going to be a general talk as a follow-up to reading chest X-rays.
That will make even sense because you'll not be there the other weekend. So yeah. We'll see how it works.
Okay.
So guys, if you're waiting for the exams, all the best. Just know that you're just one step away from sitting in my position, maybe 2 steps away from being at the position of Dr. Gichoya.
Okay, thank you, everyone. If you get the vaccine, please take some Tylenol. That is very helpful for the symptoms, like the fatigue and everything, and just take a lot of water and rest. And see you next week. It's either me or Dr. Musheru.
Thank you. Yeah.
Okay, bye. Sawa, Doc, I'm going to end the call now.
Nimeshukuru sana. Asante.
Okay.
Yep.
Love you.